So my name is Róbert Rapčan, and I'm a medical director of European Clinics. And this presentation is going to be about endoscopic facet joint and SI joint denervation, our initial experience. We're talking about facet joint pain of lumbar spine or any other part of the human spine. We're talking about prevalence of 40 up to 70%, different studies, and increasing with age with facet arthrosis. There's some clinical science during examination. All of them are unreliable. And we have also some kind of no problem with bending forward, problem with bending backwards, and patchy distribution of the pain on contrary to the radicular distribution. But it's not always exactly like that. All of us, we know it. We also know that facet joint is innervated by medium branch of the dorsal ramus, and its selective block is one of the best, if not the gold standard of the diagnostic process for the facet joint syndrome. So we see the anatomy, and what is very important when we're performing the diagnostic block, we need to think about anatomy of the innervation. We need to perform at least 2 diagnostic blocks for the one facet joint, and it's very important to place our needle under tunnel vision exactly where the medium branch block or medium branch is precisely. When we're talking about treatment, we're normally using conventional RF technique or cryoablation technique with the anatomical placement and no nerve visualization, no ablation visualization. So all these things are sort of limiting factors for the successful final treatment. But of course, in very experienced hands, we're not saying it's not a successful treatment, but this is a new concept. We're talking about endoscopic RF denervation in first hand, and we started doing it just a very short video time ago with transforaminal endoscopic instruments. We were using them to locate the medium branch. So we just went to the under X-ray control to the place where the medium branch is, and at this place we just did a tissue. We took away the tissue around the medium branch. We visualized the medium branch under endoscopic control, and with a special RF probe, we just burned the medium branch. But it was a denervation procedure, and if you don't mind, I will carry on because this is just showing how we did it time ago. With endoscopic instruments for transforaminal approach, and it was a denervation procedure. But what we're doing now is a new concept of maximal ablation treatment modality. And this modality is not for denervation. It's for use of high heat and rotational capsular tissue shaving. And the concept is to take away the capsula to do the irrigation, take away the inflammatory process from the facet joint to achieve the rehealing of the capsula and the capsular tissue, and just to get the better condition of the facet joint with the disappearance of the pain syndrome. So it is not a denervation procedure, it's a treatment procedure focused on a capsular tissue of the facet joint and facet joint itself. Simple set for that. You have some kind of endoscope, a dilator, working sleeve, special K-wire, and a manual shaver. Single-use kit. You have to use the X-ray anatomy. If you know how to do it, you will find an AP projection in your facet joint, and then you place your K-wire just either inside the facet joint or just medially from the facet joint on the bone of the inferior articular process, medially, one more time, medially from the facet joint. Then you carry on with the dilator. After the incision, you go inside with a dilator, you check in lateral position. When you're in lateral position, you need to see exactly that you're approaching the facet joint and the place where the facet joint is. You advance then the working canal under fluoroscopic guidance. And when you have the working canal anchored on the medial side of the facet joint on the inferior articular process, you're going inside, you're taking out the everything except for a working sleeve, and then after removal of the dilator, you go inside with the endoscope, with the grasper, you take away the tissue, then you do some radio frequency burning, and then you remove the endoscope. After removing of this endoscope, you're using a special manual shaver, and after shaving of the tissue, you go back with the endoscope, and you just take away the rest of the tissue, and you do the final RF treatment application of the heat. When you do this and you see that everything looks like it's supposed to look, you're just finishing the procedure, and you need to do minimum 2. Normally it's like 3-4 levels when you are performing this procedure. This is just to understand X-ray anatomy in AP and lateral position for everybody who is going to do it and is not 100% familiar with X-ray anatomy. Technical notes: it's an endoscopic procedure, visualization of capsule and surrounding tissues, resection, coagulation to see joint gap and surrounding bone, finalizing of the decapsulization with RIMA if necessary, denervation of lateral aspect of superior articular process, and slipping down to thoracic to the transverse process and medium branches if necessary. So you can really do the complex procedure treatment and denervation if necessary, but we're trying to avoid the denervation of medium branch. Just for you to see the video how to do it. Yeah, this is the basic anatomy, how it looks like in the endoscope, and this is short video to see. There's some nice music, so for that. So you're taking away all the tissue first, and you do so. You're using your RF probe to have no bleeding and to see exactly what you're supposed to see. And then when you're nicely taking away everything, you're getting finally to when the capsule is away, you're visualizing the facet joint here. And you're going to the final part. And here, that's excellent. And you have it like that in the final position of the decapsulation. Evidence-based support is a very complicated thing, and I don't want to talk too much about it because there is definitely lack of evidence for this type of procedure. We can compare with cryoresotomy. We're doing our own studies comparing cryo, conventional RF, and this endoscopic denervation or endoscopic capsulotomy. We have our initial data showing first results after 6 months, and I would like to say it looks like it's in favor of endoscopic procedure, but it's too early to say anything. There are some studies already performed, and those studies are showing some kind of support of endoscopic treatment because it looks like the minimum time of pain relief in comparison with other shorter lasting pain relief procedures like conventional RF or cryo are 3 years and more on follow-up, which is supposed to be an advantage. What I see as an advantage is really that this concept is not just focused on denervation. It's really focused on sort of treatment of the facet joint, taking away maybe the inflammation and giving on arthrotic facet joint a sort of a little bit better quality. Of course, increased costs, need of the surgical theater, increased demand on equipment and on personal resources, and of course, increased demand on competence. you have to be familiar with the endoscopic technique. If we're going for endoscopic, if we're talking about endoscopic denervation of SI joint, there is a different concept. This type of procedure is purely denervation, and it's a full endoscopic ablation of the large sensory SI joint innervation complex. And we're going for S1, S3 foramina, and maybe if necessary, we'll go for dorsal ramus of L5 because it's supposed to be a complex denervation. It's the same like any other procedure on SI joint, just here we're doing it under direct visualization. When we're talking about diagnostic, I have to say a few words about it. If you do all the provocation test and intraarticular diagnostic injection is good enough, but maybe sometimes good enough is not good enough. It's very important to think about low back pain and SI joint, and you have to realize that 85% of low back pain has no MRI findings, and all the gluteal or leg symptoms from ligaments are much more common than those from damaged nerve roots. That's a very important fact. SI joint itself makes up to 15–30% of low back pain. It's good to realize, like a Japanese group of researchers of SI joint are saying, it's like an earthquake. The walls collapse first and electrical installation last. So it's like a human body. All the ligaments and muscles are like walls, and nerves are like electrical installations. So don't think about SI joint as a last thing. You always take it as a possible first problem or one of the first problem, and don't focus on nerve roots only when you have some kind of back pain. Anatomy, all of you know about the anatomy and innervation of the SI joint, which is very complex. It's coming from maybe L4, L5 medium branches, maybe even the higher levels. And then you have to think about lateral branches of S1, S2, S3, which is a posterior innervation. And then also we have an innervation of the anterior part, which is impossible to treat because we don't have access to the anterior part. And what is important to realize, nerve endings were confirmed in both the capsule of the SI joint and the dorsal ligaments area of the joint. Think about pregnant women and SI joint dysfunction during pregnancy, pregnancy-induced joint inflammation, like a form of sacroiliitis, or pregnancy exaggerated sprain of the supported ligaments because of pregnancy. Categories are different. The most common we are facing in our pain clinics are SI joint dysfunction, which is essentially a minor subluxation of the joint and not inflammation. So you will not find anything on your MRI. You will not find anything on CT. It's mostly caused by leg length discrepancy, gait abnormalities, low-grade trauma like jogging, things like that. Then, of course, you can have infections, spondyloarthropathy, neoplastic tumor problem, trauma, or even iatrogenic because of SI joint damaged during obtaining the bone graft, for example. But all those things are much less likely to happen than SI joint small dysfunction. Scoring system is also existing for the diagnostic process. You see on this what you can use for that, and then positivity cutoff point of 4 can give you a high chance that the diagnosis you're facing is sacroiliac joint. Differential diagnostic, it's not easy because you can have a facet joint, even nerve root and discogenic pain, and the pain patterns are very similar. So it's very, you can be confused. Imaging methods, especially on dysfunction, are not helping you. It can help on inflammation, can help on tumor or some trauma, but on dysfunction is not helping you. Sometimes ultrasound is showing a sort of irregular tissue in the posterior sacroiliac ligaments, and this can be helpful. For the differential diagnostic, you can use like 14-finger tests, things like that, but again, it's not very reliable. It's not easy to use it just to differentiate your sacroiliac joint pain just with 1-finger test. And you have to be more confused. You have different differential diagnosis like entrapment of supraocluminal nerve, iliolumbar ligament problem, sacrotuberous ligament syndrome, piriformis syndrome, superior gluteal nerve problem, or even hip joint causing trouble similar to sacroiliac joint. So you have to be very focused what you're dealing with, and to get to the final diagnostic of the SI joint, to exclude whatever you can exclude with whatever you know how to do. And then you're coming to SI joint injection and the first choice for the treatment of SI joint. We do recommend now to perform periarticular injection, can be more effective in most patients with SI joint disorder than intraarticular injection. So the preferred algorithm nowadays, we recommend firstly to perform a periarticular injection if ineffective, then perform intraarticular injection if effective. Both tests are giving you a positive diagnostic information about sacroiliac joint being a pain generator. If you confirm the diagnosis, then you carry on with either therapeutic injections like prolotherapy, steroids, PRP, hyaluronic acids if it's intraarticular problem. If not if this is not effective enough, you go for some kind of denervation techniques like radio frequency, cryo. If this doesn't help, then you go for endoscopic SI joint denervation. And finally, in some indications, you can use SI joint fusions. For the periarticular injection, there is a technique of 4 sections to inject. You see all those areas just to cover everything and to get as good a result as possible. And SI joint basic clinical algorithm, diagnostic injections, periarticular or intraarticular, treatment injections, cryo, radio frequency ablation, endoscopic denervation, and in some cases, surgical treatment. I have to emphasize, inevitable part is a focused rehabilitation. If we're talking about endoscopic denervation of the SI joint, you're placing your instrument, your working sleeve exactly on the lateral edge of the foramen. And then you see a part of the lateral part of the foramen, S1, S2, S3, and the lateral bony edge of the foramen. And when you are there, you're taking away the tissue, you visualize the bone, and finally, what you do is you are burning lateral branches. So exactly like you can have a look here. You see the foramen, this entrance to the foramen, and this is the lateral. 6 o'clock is the lateral part of the sacral bone of the foraminal edge. So you are taking away the tissue, you visualize the bone, and then you use your radio frequency probe and you do the RF treatment on the lateral edge of the foramen just to get the proper denervation of the sacroiliac joint, the posterior part. Of course, you can also perform additional L5 facet, L5 dorsal ramus as well. Key message: do not forget SI joint as a potential pain generator. And my additional information is, do not take every low back pain as an SI joint. Thank you very much for your attention, and thank you.